I'm Dr. Sid Kennedy, and it's my pleasure to welcome you to tonight's HRI Talk. I'm the Executive Director of HRI and a psychiatrist. Thank you so much for being with us this evening. And for those of you who are joining HRI Talks for the first time, we're exploring research ideas and discoveries that are helping to power progress in mental health and addiction. These are free public talks, and our aim is to offer hope and to shed light on the importance of mental health research and the far-reaching impact this work can have for friends, family, loved ones who are dealing with mental illness and addiction. Before we begin, please note that closed captions and live transcript have been enabled for this event. If you'd like to see live subtitles or transcription this evening, you can turn these options on by using the CC button on your Zoom display. I'd like to begin this evening by sharing that the offices of HRI are located on the traditional lands of the Anishinaabe, the Atawandaron, the Haudenosaunee, the Métis peoples, and the treaty lands of the Mississauga of the Credit. We invite you also to share your land acknowledgements on the chat, or simply let us know where you're from. We at HRI acknowledge that our history as white settlers has caused suffering and trauma for a great many people, and we frequently reflect upon the deep and lasting impact that these traumas will have. We support the Truth and Reconciliation Commission of Canada and their call to action. We are continually working to be more inclusive in our research and everyday practices. We want to do our part to promote reconciliation and healing, and we invite any input you might have on how we can do better. For those of you who aren't familiar with HRI, we are a national mental health charity. We conduct applied research with the goal of improving mental health and addiction services in ways that can benefit more people sooner. We are proud to work with leading scientists, clinicians, and trainees from across Canada and beyond. So let me tell you a little bit about tonight's format. We will start with a moderated conversation with our guest panelists that will last approximately 30 minutes. Presentations are based largely on questions submitted by registrants at the point of signing on. After 30 minutes, we'll shift over to live questions submitted by you, our audience members. We'd love to hear from you, and if you have questions, please use the chat or the Q&A button at the bottom of your screen at any time during the presentation. And we'll get through as many questions as possible before we wrap up at 8 o'clock Eastern Time. Note that Code of Conduct for Chat has been shared in the chat box. Let's all work together to ensure this remains a safe space for sharing and learning from one another. Now, before we jump in, I'd like to note that some of the content we'll discuss tonight may be rather sensitive or difficult for those of us whose lives have been directly affected by mental illness or substance use. If at any time you feel as though you need some support, we encourage you to visit Wellness Together, all one word, wellnesstogether.ca, where you can access mental health and substance use support at any time of the day or night. This is a free and excellent resource for Canadians. So if you could use help, feel free to contact Wellness Together Canada. Finally, before we begin, I'd like to extend our deepest gratitude to our corporate sponsor, CIBC, and our supporting sponsor, KPMG. HRI Talks would not be possible without your generous support. So without further ado, I'm actually excited to introduce the first presentation of a comprehensive report entitled Psychedelic Medicine, a Rapid Review of Therapeutic Applications and Implications for Future Research. Written in collaboration with Queen's University, Kingston, the report reviews a full range of studies on psychedelics as medicine. The report will be launched on HRI's website at the end of this talk. Guests of tonight's talk will receive a link in the chat, and tonight's panelists include the report's primary authors. So it's my pleasure to present the three primary authors who will be our speakers tonight. Dr. Brian Rush, Senior Scientist at HRI and Scientist Emeritus from the Institute for Mental Health Policy at the Center for Addiction and Mental Health. Dr. Olivia Marcus, Postdoctoral Research Fellow at New York University, Rory Myers College of Nursing, and Dr. Ron Shore, Research Scientist, Queen's Health Sciences. I'd also like to acknowledge Dr. Ken Tupper from the Public Health School at University of British Columbia for carrying out an independent review of this extensive document. So it's my pleasure to introduce Brian Rush as our first speaker.
Hi, everybody. Thanks, Sid, for the introduction. And I've seen the names coming in on the chat. I see so many friends and colleagues. So I appreciate all the support from everybody joining in today. So with Olivia and Ron, we've prepared a few slides to give an introduction to the report. It's intentionally brief. It's set up as just that, as an introduction, and the report will be available. So we've organized the presentation really responding to questions that have come in and leaving lots of time for further conversation. So we hope to have a conversation with you. Without further ado, let's go to the next slide. So getting everybody on the same page, what are psychedelics? This is an introductory section of the report. This is one definition, substances that share the subjective experience of a significantly altered state of consciousness with a profound capacity to reliably induce shifts in perception, cognition, and mood. You can probably find other definitions. This is one that we were comfortable with in introducing the report. As in any kind of research topic, this gets broken down different ways. This is also the way we agreed in the report, and the literature is generally consistent with this breakdown. So classical psychedelics, these are examples: LSD, psilocybin, DMT. Without going into the details, they share a common mechanism in the brain by which they exert their quote unquote neurobiological effect. So they share brain chemistry, put it that way. Atypical psychedelics, two common examples, MDMA and ketamine, have alternative mechanisms of action in the brain, but share many of the same effects on perception, cognition, and mood. There's variation, but when we talk about psychedelic medicine, psychedelic assisted therapy, these two big categories, classical psychedelics and atypicals, are often kind of put together. But the research is quite distinct. And in our report, we report on the impact, therapeutic evidence, et cetera, safety for each of these substances separately. Another important term is entheogen. It's an alternative term. It could include any of the above substances, but it refers to naturally derived substances, psilocybin mushrooms, peyote, ayahuasca, So as opposed to psilocybin, which is a synthesized medication, an entheogenic approach would refer to psilocybe mushrooms. These are typically used in a ritualistic context, and our report goes into some of the different ways in which they're used. There's research in these contexts on an entheogenic basis, and there's research on the classicals and the atypicals. So this is a bit of an introduction. Next slide, Kylie. We are also here to talk about psychedelic-assisted medicine or treatment. And this is a simple way of formatting that for you. It's a form of therapy, typically psychotherapy, that involves the use of any of the above substances for the purpose of facilitating therapeutic breakthrough or insight. Psychedelics are often seen as an amplifier or a catalyst to that therapy. This becomes very important in the context of the research where, by and large, with very few exceptions, ketamine being one, we're talking about the impact of a substance combined with psychotherapy or some psychological supports. And again, consistent with the entheogenic work, this may include various ritual ceremonial practices which have their own therapeutic benefit and contribute to the evidence base for safety and effectiveness. So you'll find the report covers both the psychotherapeutic world of these medicines and also these ritualistic ceremonial practices, which have a strong Indigenous base. Next slide, Kylie. There's a long history to this. The report traces it. Several publications cited in the report go into some detail. By and large, these substances showed great promise as psychotherapeutic aids in the 1950s and 60s. Quite a bit of this research was done in both Saskatchewan and in Toronto. At the time, the Addiction Research Foundation. Great promise. Then a lot of events and contextual factors converged to basically not shut down completely, but largely halt the research. Subsequently designated as quote unquote Schedule I substances under the UN Convention. There's a formal definition of that, which partly states that they have no therapeutic benefit. In the Canadian context, they're now under Schedule III within the Canadian Controlled Drugs and Substance Use Act. So there's been some research continuing through this, the next 70s, 80s, 90s, but not very much. And largely because of the controlled substance designation, the political climate, funding opportunities. And there was a lot of methodological issues with some of that earlier research, again, reviewed in the report and reanalyzed to provide a different understanding based on some newer methods of analysis. So that's the historical context, which leads us to the next question. I often refer to it as the Amanda question. My wife, Amanda, asked the question. You can go to the next slide. And I see Amanda's on the call. Why today? Like, what's new about this today? Like, why today? And I think there's really three reasons. One, we have what's referred to as a treatment gap in many countries. The need for mental health and substance use health services is just greater than our current capacity to respond. We have many questions of availability. We have many questions of equitable access. And in short, we need more tools in the toolbox, or we need more medicines in the medicine bundle, would be another way to put it. Secondly, many people are not helped by current options. This is not to say they're not effective for some. There's many good interventions out there for both mental health and substance use health, but many people are not helped by those options. And thirdly, the current evidence is quite strong. This was our focus in the report. What does the evidence really say? We've summarized that for you. We'll give you a highlight in a moment from Olivia. But basically, the evidence is strong enough that we should be continuing this work, moving the research forward. So I think without further ado, I'm going to hand it over to Olivia. Sid has also done a nice introduction for Olivia. Olivia played a significant role in the report and is going to give us a brief overview for the purposes here of the therapeutic benefits of this work. So Kylie, next slide, and then Olivia will take over, and I'll go on mute. go ahead with this one.
Thank you, Brian, for passing it on, and thank you, Sid, for the introductions. To summarize this slide, what we aim to do in this report, as you can see here, is synthesize the excellent body of research on the safety and effectiveness, or really the safety and efficacy of psychedelic-assisted treatments and support of people experiencing challenges related to mental health and substance use and other related health conditions. We analyzed the various considerations relevant to research and development in this area, with a specific attention to a need for diversity in methods, study participants, and as well as practitioners and scientists. And then highlighting as well the gaps in knowledge and opportunities for research investment in the Canadian context specifically. Next slide, please. So, like we've said, we're aiming here for brevity. This is a long report. There's a lot to say on what we found about treatment efficacy. And I want to start with taking attention to the language that we use here. So this report is particular to human clinical trials and related supporting evidence, meaning that we also include some observational data, some ethnographic data, some survey data, and the kind of information that these clinical trials are yielding refer to efficacy, which is a term that concerns how certain medicines and interventions perform under ideal conditions, and those ideal conditions being designed by the trial investigators. Effectiveness, on the other hand, refers to how well these might perform under real-world conditions. So this is why we advocate for a diversity of investigatory methods so that we can test their efficacy under specific conditions and also make inferences about their effectiveness under various real-world conditions, that is non-controlled clinical trials. That being said, the evidence so far indicates promise, as Brian said, for the safety and efficacy of certain psychedelics, certain psychedelic substances. Often, most commonly, we really want to emphasize in combination with some therapeutic support. So there is a lot of research out there focusing on specifically just pharmacotherapy, but the big take home here is that a lot of the clinical trials and a lot of the supporting evidence is for psychedelic assisted psychotherapy. And for conditions such as depressive disorders, PTSD and anxiety disorders, substance use disorders, and existential distress related to end of life, those are the kind of most focused upon in clinical trials so far. And psilocybin for end-of-life anxiety, for obsessive compulsive disorder, nicotine cessation, and treatment-resistant depression, and as well as MDMA for treatment-resistant PTSD have the most evidence behind them than trials for other conditions or psychedelics such as ayahuasca, DMT, 5-MeO-DMT, and iboga or ibogaine. And we must impress upon everyone that these trials tend to have a very small number of participants. They lack diversity in participant demographics. And so while there is promise, the reality is that there is a need for large-scale, multi-site, rigorously designed trials with a placebo arm. And so this is definitely a promising route for aspiring researchers, educators, policymakers for thinking about where funding should go, where it should be concentrated. And it also is important to point out that the reason why the use of psilocybin and MDMA for depressive disorders and PTSD and end-of-life distress have the most evidence behind them is that's where the research has been focused. So that's not to say that we haven't found promise for the application of those psychedelics for other mental health conditions or other psychedelics for those same mental health conditions. And to wrap this up, I'm just going to say that ketamine merits a separate answer here. That sets it apart from the other substances we reviewed in this report. And this is because it is an inexpensive generic medication that is legally used clinically and has been used off-label for a variety of psychiatric issues, mostly depression, for at least maybe 2.5 decades now. And so there's much more to report in the clinical and research literature on this topic. But to keep this brief, the clinical literature for PTSD that we found for, PTSD and treatment-resistant depression is compelling, but lacks consistency in methods, often doesn't include a psychotherapeutic component, which in real-world settings, it's also highly variable. Sometimes there's a big emphasis on ketamine-assisted therapy, and other times it's just used as a pharmacotherapy. And these trials as well suffer from small numbers of participants. So similarly to the other psychedelics that we've reviewed, ketamine for substance use disorders shows promise, and for PTSD and treatment-resistant depression show promise, but further research with larger population sizes are needed, as well as consistency in methods. So I will pass this over to Ron to talk about safety.
Hi, everyone. Thank you, Olivia, and thank you, Brian. As we reviewed the literature, there were some critical considerations that kind of rose to the top. So we've chose in this presentation to focus on two. I'm going to talk a little bit about safety and what we've learned from this review about the safety of these psychedelic compounds. And then I want to talk a little bit about kind of research and trial design and implications kind of moving forward and how we might want to conduct the next generation of research. So thank you. So safety is important, obviously, for a couple of reasons. One is these are human lives. But secondly, this is part of the drug development or clinical trials pipeline. So you start by establishing safety, and people can kind of absorb the medications properly and they don't do harm. And then we look, as Olivia said, about treatment efficacy and then eventually on effectiveness. But safety is also a major component of how we regulate these chemicals. So it has public policy implications as well. So what we found was that, speaking very generally, psychedelics are quite well tolerated, biologically very well tolerated, with little physiological risk. Of all the compounds we studied, and I have to declare my bias, I'm principally a psilocybin researcher, but the evidence is quite compelling for a very high safety index for psilocybin in particular. Some of the other psychedelic compounds are just a little more medically complex, and that includes iboga or ibogaine, and really which requires medical management. And ketamine has a bit of a different risk profile I'll touch on separately. The most common adverse experiences that we found in any of these publications and throughout the trials is something called transient anxiety and distress. So as psychedelics take effect, there's increase in heart rate, and depending on the psychedelic, you often increase in heart rate and breathing rate, and a sense of distortions of normal reality on set, and people can feel a little anxious about that, which is why the role of set and setting, the role of the therapist in preparation is very important. But also quite common, particularly with serotonergic psychedelics like LSD or ayahuasca, DMT, and psilocybin, as well as peyote, would be very common nausea. It could be transient or could last. There may be vomiting and headache. Usually the headache is a post-session or the next day or later that day headache. And that's thought to be somewhat serotonergic in its mechanism as well. So challenging and negative experiences are common in psychedelics. These are not to be taken lightly. They can be quite difficult. They can be an ordeal for people. But there is a belief and a compelling body of evidence that would say, to some degree, the challenge of the experience is part of the therapeutic benefit as well, whether it creates a sense of confidence or clarity or courage in meeting issues. But we do need to understand entering into this can be big work for people psychologically. A lot comes to the surface. They're very powerful emotional experiences, and people respond differently when their cognitive perceptions begin to shift. So really, we want to look at minimizing as much as possible a negative experience, but at the same time, one of the more interesting findings is people who have negative experiences will often report them as being still meaningful or spiritual or therapeutic in some way. What we don't want is for a challenging experience to last too long in duration, and that is what becomes the fabled bad trip, which is a reality and can be mitigated and minimized by proper client selection, preparation, setting, right dosage, and all that. Ketamine, as I mentioned, has a bit of a unique risk profile simply because it has more of a risk of addiction, and that's just looking at the recreational reports in some of the ketamine literature. You don't see in the animal research or in the human studies much of an addiction profile or people going back for repeated kind of reward or compulsive behaviors around psychedelics, with the exception of ketamine. And one of the things I just want to close on this slide is there's a really compelling need, not only for best practice guidelines for these therapies as they emerge and develop, but also low risk use guidelines. Despite all of our focus here on the clinical trial literature, 99.9% of psychedelic use is occurring recreationally or in people's homes or in collective settings or group settings. And really, we need to look at publishing guidelines that help people minimize the risk while maximizing any potential benefits. Questions with ketamine, or Olivia mentioned a few. One of the things is, does it have a persisting effect? That really does still need to be established. What we're finding with psilocybin and the other psychedelics is you are seeing a persisting effect that is upheld up to 4 years now in some of the literature. And obviously, one of the things we want to kind of touch on but not get into a lot is the need for regulatory drug reform, particularly to make these more accessible to people. And given the safety profile, we think that's probably most likely warranted. So next slide, if you don't mind. So I'm going to close with just a few comments on research design and then hand it back to Brian. As you can see, when you read the report, it's massive. There's really not too much like this in the world. And I do knowledge synthesis as my primary methodology. And so this is an impressive document just in how vast it is. But really what we found and what we'd like to highlight is there's a real pressing need for more what we call naturalistic or observational studies of personal use. And naturalistic mean it's not in an artificially constructed clinical trial environment. So it could be, for example, following psilocybin retreat participants, how do they do afterwards? Talking to people about their psilocybin or LSD experiences and how it might impact mental health. Those could be observational studies. The really interesting thing, and one of the biggest questions we always get, those of us who do psychedelic research, has to do with microdosing. And we've got a big section on that in the report. And it's quite interesting, but it is really clear within microdosing in particular, and I think this is true about psychedelic research in general, is there's still a need to tighten up classifications and terminology and how we understand these things. And I'll just use microdose as an example. Historically, microdose meant it was such a small dose people would take that it would be sub-perceptual. People wouldn't notice anything. But what we're finding is in the reports of microdosing, and it is interesting that the literature on microdosing is growing. The expectancy bias is real. People wanting them to work is definitely a factor, but there are lots of ways biases can creep into publications, but expectancy bias is one, and that's strong within microdosing. But it does appear that there is some merit. It does seem to have a mental health impact. It does seem to have some personal impact. And things are moving in the room here. But really, we need to clarify the language, what we mean by microdosing. And we argue that we should have microdosing, very low dosing, low dosing. And we can start to understand these things, maybe with a little more specificity. Historically, we've had some issues with inclusion criteria in the trials. So principally, I think close to around 87% of the trial participants tended to be white. And so we have real inclusion issues in terms of our diversity, equity, and inclusion. We definitely need more, not only participation from Indigenous as well as people of color, but participation in trial design. And really the voice of lived experience needs to be brought more to the table as well. And one of the things I just want to close on, and if there's a theme you remember from anything I say, is that psychedelics demonstrate what's called an exquisite sensitivity to context. And so what that means is what you do before psychedelics really can impact how they affect you. What happens after really conditions the outcomes, and what happens during in terms of the role of the setting, the influence of suggestibility from the therapist, the vulnerability of the psychedelic state. In terms of safety, one of the things I should have mentioned is because of the vulnerability under psychedelics, safety is really paramount to protect clients, both in terms of consent, but also protecting clients against possibility of therapist abuse, which has occurred, unfortunately, in clinical trials in Canada. So I didn't want to neglect saying that. But context means what happens during, before, and after. And at this point, there's lots to cover. I'll let Brian close up, and I want to thank you for your attention to all this.
Yeah, I think it's back over to Sid with how the questions go, and then I'm going to monitor the chat and bring forward questions as they come forward. So let's move into the question area. Sid, go for it.
So let me just say thank you to our three excellent speakers. I think you've given a tremendous overview of a huge document. I also want to acknowledge three students who helped in this production. Leanne Cunningham, Nina Thompson, and Caitlin Rideout. So I think it's been an excellent presentation. And Brian, you and I will share the honors here. I have some questions that were actually submitted when people registered. So I'm going to start with one of them, and then perhaps you can work from the chat and ask the next one. So I think the first question, maybe I'll ask Olivia, if you're taking an antidepressant, can you also go on psychedelic, for example, psilocybin therapy?
Yes, this is a really interesting question. And I'll start with saying that none of us are medical practitioners, so we're not here giving any sort of medical advice. And the state of knowledge on, first thing, there are a variety of antidepressants, and each are going to have a different kind of interaction with the different kinds of psychedelics, which all have their own unique mechanisms of action. So this is something to take into consideration. There are no studies to date on the interaction between specific psychedelics and SSRIs or SNRIs. There are concerns about the use of certain antidepressants such as SSRIs and MAOIs that could increase the risk of serotonin syndrome, but there's not very strong evidence to support it. And the take home here is that, well, and there's also the general understanding that if you are chronically taking antidepressants, specifically SSRIs, SNRIs, or MAOIs, it will likely reduce the effects of, or in some way alter the subjective effects of the psychedelics. And the take home, sorry, I just want to say the take home is that under proper medical supervision, you know, you would create some sort of individualized plan for how to go forth.
That's exactly the point I wanted to make, that I think you should let your doctor know if you are taking additional, and it's only relatively recently that people have had confidence from the medical studies to say there doesn't seem to be any concerns. So I'll pass over to Brian for the next question.
Well, a good one just came in around MAID and MAID being medically assisted dying, and whether ketamine, or as things move, whether psilocybin or others should be recommended for all. I'm not sure we would go for all as a recommendation, certainly given the research still needing to evolve. But it is very interesting, and I think Sarah Kramer's on the call, who's a PhD student of mine, but it's a particular focus of her PhD, that we give people permission to have a medically assisted death, but at the present time, there's very limited access to an alternative like a psychedelic assisted therapy that might help resolve a lot of end-of-life issues and distress. So I think that's kind of the conundrum at present, that we allow people to die or choose to die, but we restrict access to other things that might still be helpful. Would it be a recommendation for all at the present time, and specifically around ketamine? I think, as Sid has said, that's kind of really where some medical consultation might come in on an individual basis, and the access to psilocybin or other substances is there on a case-by-case basis through the access program through Health Canada. So it wouldn't necessarily have to be ketamine at this point.
I think there are parallels, in fact, between almost the camps who say this is intravenous ketamine and that's all you need, versus ketamine delivered in a number of different ways, could be intramuscularly or orally, for example, with psychotherapy. So we don't really have direct comparisons to address the importance of the psychotherapy in the ketamine work. But I'm wondering, in terms of the, let's say, psilocybin, do we think that it's important to have a psychedelic experience in the context of psilocybin, for example, or if that was blunted, would we get the same response? I'm wondering, Ron, if you could answer that.
Maybe a good question for Ron.
Yeah, no, that's a great question. Just so people know, there are trials underway right now, and there's a lot of work in drug development to develop psychedelic compounds that don't have visionary experiences, that don't alter perceptions in the way they do. And the reason that's happening is psilocybin, but other psychedelics have very profound anti-inflammatory effects. There is a causal association between neuroinflammation, or at least an association between neuroinflammation and mental health disorders. So the underlying mechanism is if we can reduce inflammation throughout the body, in particular neurological inflammation, it may improve functioning for people. So that's part of what's driving it, and the fact that for many people, in particular people who've had PTSD and a lot of the veterans, or invasive hallucinatory experiences, whether auditory or visual, may be very disconcerting and may not be very of great benefit for people, which is why MDMA is nice for people with PTSD. So I think that's driving some of it. And there's no doubt that, you know, if someone's on antidepressants, for example, I think the abundance of precaution where we've said don't take serotonergic psychedelics if you're on antidepressants, that's shifting, as Olivia mentioned, but people will have a more muted effect, meaning they're less likely to have the visuals. And that's true when you look at the addiction trials as well. So the psilocybin trials with alcohol use disorder in particular, people will report fewer mystical experiences. But I would also argue that despite Michael Pollan's kind of book, mysticism isn't the core mechanism of a lot of the psychedelic therapies. I think it's a factor, but they can be profound, psychological, and therapeutic even without the profound visuals. So I think that you're saying growing inclusion in trial development include people who are on SSRIs.
I'm on a bonus for the number of questions we get through. So thank you, Ron. I'm going to pass it back to Brian.
Well, there's another good one. I think we should come back very briefly because it's so important. The person asked for an example of therapist abuse, and I'll the comment you made, Ron, and I think that's good. And I'll answer, just to be aware that in the therapeutic context under a psychedelic substance, you are kind of putting yourself in a vulnerable situation. And there was one case reported through a research trial in Canada that has been thoroughly investigated by Health Canada. So let me just put that out. Another one that I'll mention, Sid, is because this also came up in some of the questions previously submitted around any recommendations, guidelines for young people and quote unquote, not necessarily pediatric, but young or young adults. And I had kind of formulated my own response to that. So if I can take that one, I'll just go for it.
Sure.
Maybe Olivia and Ron can chip in. We do know a lot more these days about the development of the brain and the length of time it takes to fully emerge out of young adulthood with whatever. We all have adolescent, some of us have adolescent children. We've gone through that experience. So there's a risk there. I think the answer I would give is we don't really know from research. We don't have a lot of studies focused particularly on younger adults, on youth. So it's work that needs to be done. But I would mention that in the traditional medicine in the Amazon in particular, that small amounts of substances, in particular ayahuasca, are used at a very, very young age with absolutely no apparent effect. They're used for cultural kind of cohesion, sensitivity to nature, communal development of communal values. But I guess I'll emphasize that in a clinical context, it's something we really need for more research. There's no current guideline, and we should have more research focused on young adults, I would suggest.
Yeah. The only thing sorry, you go, Olivia.
I'll just add that in addition to anecdotal evidence for Indigenous and mestizo use in context in Central and South America, there is an interesting study among drinkers in one of the Brazilian syncretic churches that drink ayahuasca. And it's comparing adolescents who participate in rituals with matched controls. And they found that there was no difference, and even some cases, or in most cases, increases in well-being among the adolescents who participated in these rituals. So in a very structured ritualistic context with good role models and, again, a solid framework, there's indications that it could be beneficial or at least not detrimental.
I'll just add really quickly to give hope for those of us who are older. In a review of 15 years of psilocybin clinical trial research, one of the variables we found that predicted a positive outcome was age. So the older people were, the better outcomes they tended to have therapeutically. But just to balance off the other comments about youth.
I have a different, actually a couple of questions here that relate to how do I get training from a professional perspective to be a psychedelic therapist, and particularly referencing RNs, but also other healthcare workers. Anybody like to take that one?
I'll jump in because I think we had talked about this before, that I think we're all in favor of development of multidisciplinary team approach, and there's certainly room for nursing in that team, probably other disciplines we could mention. And I would take an opportunity here to put a shout out for the need for more peer support, like very formalized peer support models. We have strong peer support programs in training and delivery of peer support programs, mental health and substance use health. And there's no reason we shouldn't be taking advantage of that lived experience in developing a therapeutic environment and a multidisciplinary team. So I don't know if anybody else, Olivia or Ron, do you want to add to that?
Yeah, there's a growing number of therapeutic training programs that are specific to psychedelics. And then to tend to the aspect of the part of the question concerning nurses, as Brian said, there's a long history of the role of nurses in psychedelic research and clinical practice. And we do, I believe, mention in the report the work of Maria Mangini, Andrew Penn, and William Rosa. So those are people to maybe start with, looking at where they suggest nurses kind of find their way in this.
Maybe if I could add or ask a kind of practical question, how do we improve physicians' understanding of these substances, their appropriate use? And perhaps I'll add as well the access. How do physicians help get access to, for example, psilocybin?
Yeah. This is a live question. So this is happening in lifetime right now, because as Brian mentioned, physicians can in Canada now order psilocybin and other psychedelics through the special access program for either end-of-life anxiety, depression, or substance use disorder. So there's a lot of physicians trying to figure this out. I think what we would recommend is a team approach. Obviously, the role of nurses is important. Death doulas are very interested in helping in this cause as well. In terms of the education, I think this is a bit of a system change or a paradigm shift in the way we've thought about mental health in the past. It's not a daily targeted medication looking at just one part of your brain. These are treatments that may occur once, twice, maybe 3 times. They have persisting effect and they're very experiential. So physicians and therapists are learning the skills of holding space while people are so vulnerable on psychedelics to understand the psychedelic experience. Often these training programs will ask people have some sort of experiential component, whether it's using a psychedelic as part of their training or using breath work to mimic the kind of altered state of consciousness. So this is all working out in lifetime, these various programs. It is a big interest of mine at Queen's here is how do we educate the next generation of healthcare providers to understand mental health differently, consciousness differently, and community differently, in part due to psychedelic research.
So Ron or anybody else, there's a kind of adjunct to that. Do people tend to need booster doses?
Often one dose is sufficient for persisting therapeutic effect that are quite significant and above standard treatments. But it's a really individualized to the patient. We're still using longitudinal studies. Many of the trials used 2 or 3 doses. Some used only 1. You're getting an effect from 1. There is a thought you're getting more of an effect with 2. But these are maybe spread out over 2-3 weeks, not for months. A booster could be down the road, I would imagine, over time. I mean, these are things, they're visionary plants people historically have always gone back to, and I would imagine there would be a role over time for boosting as people continue to adapt to new life situations, but the literature is still formative on that.
Over to you, Brian.
Okay, I want to make sure we address a question that's not necessarily come up in, I don't know if you've got it on your list, Sid, but I'm watching the time, and make sure we address the question about how we respect Indigenous values and practices in this whole space. And I've learned a lot from Indigenous colleagues, and I know some of them are on the call today. So I think the answer is partly in twofold. One, make sure we are giving tremendous respect to where these many of these substances have come from and how they're being used. So I think it starts with respect. It moves from there to engagement and handing over the reins for how particular substances can be studied or should be studied. And three, broadening our interpretation of evidence, include an Indigenous perspective on how we understand knowing or so on, which I think bridges into another question. But I want to kind of, I don't know if Olivia, you've got a lot of experience working in South and Central America. If you want to add to that, I want to make sure we cover that well today.
Yeah, I think you covered it well enough. There's a big role for recognizing autonomy of practice and autonomy in spiritual and healing practices, political and policy developments and relationships with different Indigenous, First Nations, and Native communities, and really foregrounding and again engaging with these communities as we go forward.
So maybe Sid, I think we've covered that one. I wanted to make sure we had time for that.
Yeah.
I think I can bridge to another one, which I think is a little bit related, a question that came in on what are the barriers to observational research? And for the person asking the question, observational research is kind of a broad term that can cover anything from, doing a study with comparison groups and so on, but not in a controlled, not in a clinical trial, randomized assignment.
Mm-hmm.
So observational research does not always mean kind of anthropological, where the person is embedded, because the question also asked like, how do we avoid the observer effect, so to speak? So observational research is kind of a broad term that wouldn't always necessarily include some bias of the observer. But I think it's worth mentioning that even researchers doing a clinical trial are bringing bias. There's bias in choice of methodology. There's bias in your training, et cetera, et cetera. So part of the research enterprise in general, and we address some of this in the report, is being aware of your biases and doing your best, whatever study design, to acknowledge your biases and be transparent about your own perspective. I have one other that came in that I think is a little bit related. I think it was a very good question. As clinicians and researchers, how do we prevent how do we prevent another shutdown? And because it really did get shut down in the late 60s and 70s, how do we prevent that? And I think that's a good question for either Olivia or Ron, and then maybe also for you, Sid, so much experience. So how do we prevent that shutdown? Maybe Ron, go for it first.
Yeah, I think a lot has changed since the earlier generations of psychedelic research. And I think that the cultural beliefs towards psychedelics have really shifted, particularly in the last few years, because of the mental health crisis, as you've mentioned, Brian, and people really looking for effective treatments and access. So I think things have really changed. Our research methodologies are much more advanced. We understand conflict, we understand bias much more. I think we've learned a lot from the prescription drug overdose crisis with opioids that are shaping how we look at particularly drug research kind of going forward. So I think we're in better hands now. But I will caution there's a tremendous financial pressure in industry funded research right now in terms of the current generations of trials. So it'll be interesting to see as they published how we manage some of those conflicts. But I think we're simply in a more advanced time, Brian. And there's so much more public interest that I think it's a safer time now.
I'd like to add a bit about the financial aspect. Well, the the methodological and ethical limitations to so much of the earlier research, where a lot of the rigor just didn't exist quite yet. So as Ron said, we've really come a long way. But also a lot of the funding for this early research in the early mid-20th century was coming from the government. And the shutdown, the so-called shutdown of the research or death of the research, which actually didn't truly happen. It was just diminished because the research funding was lessened because the trials were not showing enough solid evidence that this was being effective. So it just didn't seem to be worth the time of the people providing the funding. However, now there's a lot of investment from big pharma, from startups, from private equity investors, venture capitalists, and the government. So, we really have to be aware of this driving economic force and the market in which this is emerging, which is very much driving and dictating the terms through which we can access these things, the terms through which we perceive these substances, which is now largely as therapeutics and medicines, whereas they play a different role for many different people. So these are also reasons why it's unlikely things will get, so-called shut down again, but also why we still have a lot of issues to acknowledge as we go forth.
Sid, if you don't mind, let me make a link to this really good question that came in for Indigenous practice. Will the medicalization of psychedelics reduce access as a perverse? So there could be a shutdown in one area while one moves forward. I'll give an answer. I sure hope not. And I think our report, which gives so much attention to the Indigenous values and history and the need for sensitivity going forward in the rights of Indigenous people to traditional medicines. So I think my answer is, I hope not, but I think there might be some risk there, and I hope our report can help mitigate that risk. I'll remind people that the United Nations Declaration provides the right for all Indigenous people to traditional medicine, quote unquote, their traditional medicine. So it's a question for the courts, I think, coming forward, whether Indigenous people have a right to these substances that might come from elsewhere, not be part of their own traditional medicine, but access to them granted through historical access, and also the United Nations Declaration. So I think it's something we should all pay particular attention to, because I think it would be very unfortunate if that was an
I think there are really so many aspects to this. I think that there's a bit of a humbleness about the limited benefit of some of our clinical treatments. For example, for depression over the last 20 years, we haven't seen the breakthroughs that were hoped for in terms of understanding brain function in relation to antidepressant action or other treatments. So I think there's a bit of recognition that we should be looking elsewhere. I think your point about clinical trials is good, in that even FDA and other agencies are now looking beyond the randomized controlled trial for the reasons that you pointed out about the perhaps lack of representation in people who've gone through a standard clinical trial as not being reflective. And so large open trials may also contribute valuable information. And I think it's also the lived experience communities have brought and been recognized in virtually all of our healthcare areas to influence what we should study, how we should study it, how we evaluate outcomes, and so on. So I think these are all positives in that direction.
Yeah. If we have time for one more, I don't know if you can see the chat, Ron. Very interested in regulatory reform, especially removing psychedelics from Schedule 3. So the question is, should substances be considered separately? So a separate regulatory approach for psilocybin, separate for ketamine, et cetera, or should our colleagues at Health Canada be thinking of them as a group and trying to manage them somehow as a group of substances?
So we'll make that the last question, Brian. So Olivia, your go.
Oh, I thought he had directed
It's a good one.
but I'll start it off by saying that rescheduling these substances is a very complex process, and doing them all at once, as far as we've seen so far, is unlikely. But I'll let Ron take the answer to this.
Well, in Canada, we're fortunate because we've been through the cannabis experience. So a formerly illicit substance has been reclassified and brought in both for medical use and recreational. There's pitfalls we can learn from cannabis. Most of us can kind of see that. But I don't know. I mean, they're different. Ketamine's a remarkably different drug than psilocybin. I mean, and many people, many cultures would use psilocybin mushrooms as people would use ashwagandha as a general adaptogen in a tea. So that's not necessarily a medical therapy. So these are the questions that are going to play out in a lifetime. I don't know if I have the answer, but I think there's differentiations among the compounds. But at the same time, these frameworks are often have to do with safety and risk to the public, and generally they're quite low.
So
Okay.
I'm going to say thank you, panelists, for excellent responses, and thank you, audience, for excellent questions. So this is the end of our Q&A, and I want to thank each of you for your contributions. We promised that we would post the comprehensive review for our audience tonight. So you will notice in the chat room, we have just posted a link to the report, Psychedelic Medicine, a rapid review of therapeutic application and implications for future research. So you'll also find an executive summary and a shorter companion report summarizing the key findings. Thank you for your keen interest and attention to this important topic tonight. And you have heard it first at HRI. So, as I say, I've thanked our panelists for taking the time, thanking you, the audience, and basically we'll be posting the information in the chat room. Our next HRI talk will be in approximately 2 to 3 months, and so you can stay tuned to our social channels and email feeds. At this time, I'd also like to thank our corporate sponsors again, CIBC, and our supporting sponsor, KPMG. We appreciate your support and all the support for HRI across Canada. Thank you to everyone. Let us know if there are any particular topics that you would like HRI to take on. If we see a number of active suggestions, and perhaps you will be the driver of the next HRI talk. So it's my pleasure at this time to thank everybody, including our hardworking team behind the scenes who've kept me and Brian and everybody else on board, and our panelists. So I've enjoyed it. I've learned from it. It's been a real pleasure working with you. And I see at different times we've had about 200 people live on this webinar. So I will say good night. Thank you all very much for being with us tonight.
Thank you, Sid, for your support. Thanks, everybody. Appreciate it.
Thank you.